Yeah.
You are muted, Mikey.
Okay. All right.
The objectives of the talk is to know the anatomy, look at the basic techniques of abdominal component separation, the indications, and look at some evidences. So why do we need to do muscle release sorry about that. So why do we need to do some muscle release for ventral hernia? First, the main objective is, of course, to close the defect, then medialize the rectus muscle so that we could restore the physiology and function of the abdominal wall. So looking at the anatomy, it's very important that anybody who's going to do component separation techniques understand the anatomy of the abdominal wall, the muscular compartments, the neurovascular anatomy, such that during the technique of component separation, you would be able to preserve the physiology and restore the physiology of the abdominal wall. This is an algorithm presented by Professor Yuri Nowitzki in SAGES, and we would just like to concentrate on this part of the diagram, wherein you would note that the bigger your hernia is, the need for component separation is already there. So this is a study which actually presented. Wait, I need to go back. So this is a study which actually looked at how to comprehensively prepare for ventral hernia repair. So first is patient education and selection, which actually involves patient counseling. And you have to select your patients properly and know what kind of surgery that you're going to do. Surgical planning is very important, and most of this would involve doing CT imaging, dynamic CT imaging, which will give you an idea how big your defect is, how big is your hernial sac, are there any hidden hernias, and all other information that you would need in order to plan for your surgery. Preoperative preparation is very important because you have to look at the comorbidities of your patient. You have to look at possible adjunct therapy that you can use in order to relax the abdominal wall. And then whatever surgical technique or surgical procedure that you will choose, you have to have the proper choice on what to use as well as the mastery of that technique. Postoperatively, you should have a plan as well as to how to take care of these patients. Now, this study by Winters actually looked at CT scan in order to predict reherniation and the surgical site infection when you're doing component separation therapy. And they looked at the visceral fat volume, the subcutaneous fat volume, presence of loss of domain, the rectus thickness and width, and the hernial sac volume. And after analyzing the data, the conclusion basically said that the visceral fat volume, the subcutaneous fat volume, and the hernial sac volume could actually predict the possibility of herniation and surgical site infection postoperatively. So there are basically two techniques that we can use for muscle release. We have the anterior component separation and the posterior component, or the TAR. So what are the relative indications, contraindications for component separation? Of course, one would be if there is extensive destruction of the components of the abdominal wall, such as if there are injuries in the superior and inferior epigastric artery before the surgery or during your surgery, and if there are denervation injury from previous surgery, as well as muscle loss. Contaminated operative field is also another contraindication due to the possibility of inability to use the mesh. So, of course, we know that the anterior component separation was first reported by Ramirez in 1990 with the main aim to medialize the rectus. You gain an 8 to 10 centimeters after doing the procedure, but it is associated with problems and skin complications. So we know the steps. You release first the external oblique aponeurosis, and then subsequently dissect in between the internal and external oblique. And if this is not enough, then you might need to release the posterior rectus fascia to have further advancement. So this is how big the skin flaps are done, and this is why we see skin complications when you're doing this procedure. So this is some aggregation of data that we would note that the complications for the skin is quite high, and the recurrences can actually go as high as 22%. With the skin complications, the endoscopic component separation technique was invented, and this actually obviates the chances of skin problems, and this is how it will look like. Now let's look at posterior component separation. This was popularized by the group of Yuri Nowitzki. We all know the technique. We first do the retrorectus dissection, and then subsequently go laterally, preserve the nerves as mentioned by Victor, and then incise the lamella of the internal oblique, identify the transversus abdominis muscle, and you have to be very careful in the dissection of the transversus abdominis muscle. It is, of course, best to dissect this part in the most cephalad portion of the abdomen. And subsequently, you can close the medial part and then do your mesh as wide as possible. So this is a study done by, again, the group of Yuri, looking at how far the myofascial medialization would be. This was done in a cadaveric specimen. So the medialization was measured by first the retrorectus dissection. The second is incision of the posterior lamina of the internal oblique, the transection of the transversus abdominis, and the retromuscular dissection. And they found out that they used pulleys in order to look at the medialization. And they found out that for the posterior part of the rectus, you basically have these advancements. After retrorectus dissection, you have 7.5 centimeter advancement. After incision of the posterior lamella of the internal oblique, 8.3 centimeters. After transversus abdominis transection, 9.5. And after a full retromuscular dissection, you have 11.2 centimeters. Anteriorly, at the anterior rectus sheath, after the first step, you have 7.6, followed by 8 centimeters, and very similar for transversus abdominis, 8.6, but a little bit more limited on the anterior advancement after retromuscular dissection. So you have to consider all of these advancement measurements while you are considering the type of procedure that you're going to do. So this is again a publication of their group, a fairly recent publication, and looking at technical considerations in doing the posterior component separation. The first requirement is that you have to know your anatomy very well. You have to accurately identify the medial aspect of the rectus to start your retrorectus dissection. And you can do this either via the anterior approach or the posterior approach. Of course, the anterior approach has the advantage of staying extraperitoneally, while the posterior approach has the advantage of doing adhesiolysis of the peritoneal adhesions from the abdominal wall. You have to preserve the epigastric vessels and nerves when you're doing this dissection, and know the peculiarities of the abdominal wall when you are doing the dissection at the xiphoid area and the pelvic area. When you are dissecting the TAR plane, it is important that you know where to incise the internal oblique aponeurosis so that you would be able to preserve the intercostal nerves. Of course, as I mentioned before, it should be best started as far cranial as possible. And during the dissection of the transversus abdominis muscle, you have to separate it from the underlying thin posterior transversus abdominis fascia and peritoneum with a right angle clamp. This is one area of the dissection that you can actually do some damage if you create micro perforations or very small perforations not visible to the eye to the peritoneum, because that can cause interstitial herniation later on. And subsequently, when you are dissecting the TAR plane, it's dissected bluntly by your hand, and put your mesh, your wide mesh, from one lateral side to the other, put your drains, and subsequently close the patient. These are some aggregated data on the results of posterior component separation. The wound complication rate is about 6 to 25%, and the recurrence rate is quite low at 4 to 7%. A more recent data published, and this is a systematic review of several reports on the TAR. You would note again that aside from this big data wherein they have a higher recurrence rate, the main recurrence is still at about 5 to 6%. Now, the reason for this recurrence rates, which are quite high in this series, is because they have basically done a more complicated procedure, such this procedure has intracutaneous fistula, this has parastomal hernia, this is an open abdomen after trauma, and these are cases wherein you had contaminated fields in the surgery. So when do you do TAR? As mentioned by Victor, the rectus width and the defect width has to have a ratio of about 2:1. The study behind this is this publication done also by the Carbonell group. And what they did is that they retrospectively analyzed the data on the patients that they did component separation. And they utilized CT, measured the rectus width to the hernia width ratio, and they noted that the higher the rectus width rectus width and defect width ratio, chances of closure with just a retrorectus repair would be at about 90%. If your RDR is more than 2, then chances are you would be able to close it with just the retrorectus repair, but below 2, the chances of doing a muscular release is there. This is a meta-analysis which looked at the comparison of the PCS TAR over OAC. And you would see that the number of cases is almost very similar. And to put it simply, the data would state that the posterior component separation with the TAR and the open anterior component separation basically have comparable outcomes for complex abdominal wall reconstruction for midline and ventral incisional hernias. This is another paper which actually published about seroma management. We all know that when we are dealing with big hernias, then seromas could be part of our problem. And the algorithm would state that if you have a clinical suspicion of seroma and they are symptomatic, then the advice is drainage. If they are asymptomatic, you have to look at inflammatory markers such as the CRP, the WBC, and the neutrophils. And if your inflammatory markers are elevated, then chances are you might be dealing with a possible infected seroma and you have to drain. If the inflammatory markers are normal, then you can do your imaging either by CT scan or ultrasound. And if the seroma is more than 100 ml, then the advice is also to drain. This is an NSQIP data, 2005 to 2013, looking at the use of component separation for the elderly. And if you look at the data of the elderly of more than 6 to 7 years, this is actually very similar to the 43 to the 66 year, which actually tells us that even though your patients are quite old, you can still use safely component separation treatment. What about loss of domain? We all dread this patient coming into our clinic and having to handle them, but someone has to handle them. And these are the definitions for loss of domain. Some would define it as the volume of the hernial sac and visceral content greater than the capacity of the abdominal cavity. These authors define it as defects more than 10 centimeters or more than 20 centimeters, or inability to reintegrate the viscera back into the abdominal cavity, or if 50% of the abdominal contents are outside of the abdomen. But probably the most useful of a definition would be a ratio of the hernial sac volume and the abdominal compartment volume. If it's more than 20 to 25%, then chances are you have loss of domain. Of course, you do this measurement by looking at CT imaging and you do volumetric evaluation. So what are your options? These are your options. You can do preoperative progressive pneumoperitoneum, Botox injection, visceral reduction, which is actually not very popular because it entails bowel resection, use of tissue expanders, as well as skin flaps. So this is a study which looked at the use of the different techniques for loss of domain. So they looked at preoperative pneumoperitoneum, tissue expanders, and Botox. And to put it simply, the Botox coupled with muscle release had a 100% closure rate compared to the PPP and the tissue expanders. For the PPP, they do have some complications of 12% subcutaneous emphysema, and wound infection, for the tissue expanders, there is actually a 7.1 chance of wound infection as well for the tissue expander. So let me talk about a bit on chemical component separation. This is a randomized controlled trials on 46 patients that underwent laparoscopic ventral hernia. What they did is they injected either the 3 layers of the lateral compartment or just the external oblique and internal oblique. So this is, has some relation to the question of Jaideep regarding preserving the transversus abdominis as the corset of the abdomen. And these are the basic characteristics of the patient for the 2 groups. And you would note that the parameters in terms of the age, the BMI, the transverse size of the defect, as well as number of previous successful hernia repairs are very similar for the 2. And what they did is that they looked at reconstructed images. This is pre-Botox, and this is after the Botox with the 3-layer treatment. And this is the 2-layer, meaning the internal oblique and the external oblique only, pre-Botox and after Botox. And when they looked at it, the data would state that even if you just inject just the internal oblique and external oblique, the relaxation that the Botox will do is actually statistically equivalent. And basically, the conclusion would state that the transverse abdominis muscle, since it plays a significant role in truncal and spinal stability, and if you spare it from paralysis, it may preserve an important component of abdominal wall physiology during the, after your surgery and while the patient is recovering. This is, again, another series looking at preoperative administration of Botox. 37 patients injected at 1 month prior to the surgery, and the mean facial defect of the this series is 12.1 centimeters. So they looked at possible complications of the use of the Botox, and the only complication that they detected is 1 patient complained of pain after the injection, and of course there is adequate lengthening of the lateral muscles after the injection seen on CT. And if they looked at their data in terms of complications, it's actually comparable to the data on the complex ventral hernia repair. What they didn't find out in this series is that they cannot find the optimum dose that they can use for this technique. Lastly, I have some words on training. So this is the group of Ferdinand and Kocherling published in 2019, and they looked at the need for specialized training for abdominal wall hernia. So this is the access group of the European Hernia Society. And the main statement is that the general surgery training has the intention of training surgeons only up to a standard for independent practice. But problem is, worldwide, there's no standardization of the expected operative experience in US surgery training, and various surgical curricular requirements will invariably differ as well. So these are factors influencing groin hernia. You would note that a tailored approach is needed because of all of these parameters that might give you complexity in inguinal hernia repair. This is for ventral. Again, a tailored approach is recommended due to the several complexity factors that are involved, which will make us tailor our operation for this type of repair. So the access group is actually recommending that there is a need for tailored approach for both inguinal and ventral hernias. Various techniques are needed with its own learning curve that needs to be mastered. And there are factors that may affect the outcome of our surgery. GS surgery does not answer the need for this mastery. Therefore, we need additional training for hernia and abdominal wall surgery, and we need to recognize and credit specialists in abdominal wall surgery. So to summarize the issues in training, residency training in general surgery will address non-complicated cases, but there is a need for specialist training for complex abdominal wall reconstruction techniques. There is a need for standardized hernia fellowship training and probably a hernia school. Thank you for your attention.